All right, so the very first thing we're gonna do is we'll take a straight AP shot and we'll start tilting toward the head until we level off this S1 end plate. That view is gonna be called our outlet view, and what we're looking for here is our foramen, mostly our S1. We wanna see the nice brow of the S1 foramen and make sure the S1 end plate is leveled off. Once we have that, we will put one of our guide wires over both S1 foramen and draw a line out laterally onto the operative side. Once we have that S1 line, we'll throw maybe 10 to 20 degrees contralateral, highlighting this lateral edge, and we'll draw a line intersecting the S1 line on that lateral edge. Our starting point will then be 1 to 3 or 1 to 4, depending on the patient's thickness here. The thicker the patient is, the further we have to start, because we're going to be coming back at an angle. Once we have those two lines, we're going to come in with a spinal needle, dock up with this ilium. We're going to check our views to make sure everything looks good. If your needle is too straight up and down, that means you need to start further lateral on the skin to get that kind of 30 to 45 degree angle here. If your needle's too flat to get to the ilium, that means you need to start a little more medial. We want that needle to be coming off the skin at about 30 degrees or so, coming down and hitting the ilium. Once we have that and we have a good starting point, we'll make our incision, kind of start at the S1 line and cut south. Once we have that, we'll bring our introducer in. We want our introducer to dock up right out laterally from the S1 foramen, and we want to aim just above the S1 foramen. So we'll do that in our outlet view. Once we get some purchase and we like where we are, we'll go to our inlet view, where we're looking for this anterior edge, and we're also looking down the lateral edge of the ilium. We're kind of shooting right down the length of this. So all of your foramen are in a straight line right down the length of the patient. So you won't see any foramen here, but you will see your anterior edge and your lateral edge. So we want to make sure that the pins coming across, or the introducers coming across, kind of at a 45 degree angle in your inlet view, and we're aiming for this anterior wall, but we just want to make sure we're not going to breach it. We will then bounce back and forth between inlet and outlet, making sure in outlet we're not hitting a foramen, and in inlet that we're not coming out anterior. Once we get most of the way down, we will then check a lateral, because one of the only things we can't see in inlet and outlet is this alar line. So right along here, we're just checking to make sure once we get all the way down that we don't pop out of this ala. Because like I said, in outlet, you can't see the ala, and in inlet, you can't see the ala, or at least you can't see yourself coming through it. So we check a lateral, make sure you're not going through that ala, and then if everything's looking good, we come back to inlet, outlet, keep tapping. Safety stop contacts the lateral edge. You'll take off your little cap, you'll put your guide wire in, you'll tap out your introducer, then you'll go back to either an inlet or an outlet. In inlet, everything's going to be lateral to medial, so you'll bring your reamer over, you'll dock up. If you're in inlet and you're either too lateral or too medial, you'll be able to see. You change your instrument angle, line up, start screwing in, give it a couple turns, get a little purchase, and then whatever view you're in, check the other view. So in outlet, everything's cephalad caudal. So outlet cephalad caudal, inlet is lateral medial. You keep checking your two views, making sure you're following the guide wire. You ream all the way down to the safety stop. You then click it into reverse. You back it out. You can take the T-handle off if you need to, and then hand wiggle out the reamer. We then decide what size screw we want, 40, 45, 50, or 55. Come in, dock up with the ilium, bring the driver on, lock it in, start screwing in. We'll stay in inlet for your lateral medial, go to outlet for your cephalad caudal, make sure everything's in line, let the screw do the work, go all the way down until the proximal head here contacts the ilium, get it nice and snug, and then call it a day. You'll move your second screw. First screw is going to go above S1, second screw is going to go below S1. In your inlet view, they're going to be almost superimposed in parallel because they're both coming in kind of right here. So they almost look like they're stacked on top of each other in inlet. but an outlet is where they should be deviating. So same exact set of steps, come across, shoot below S1, make sure you're not coming out anterior. We're not so worried about the alar line now because we're actually shooting like straight down this way, which is the most anterior part of the joint. So we don't really need to recheck a lateral, but you can if you would like. And then mostly just inlet, outlet, back and forth, get it across, ream it down, select your size screw, put it across.
And any post-op recommendations?
So post-operatively, we recommend patients for 2 weeks, take it easy, try not to drive, no hard impact or anything. They can get up and walk same day, they're ambulatory right away, just light activity. 6 weeks, no NSAIDs, and no lifting more than 10 pounds for 6 weeks. And then for 12 weeks, no running, jumping, hard shock into the SI joint. These screws, because they're 3D printed titanium, should be pretty much fully fused at 12 weeks. So we want to keep them light for 12 weeks, make sure it really fuses well, and then once that fusion's solid, they can start doing whatever
When do they
want.
feel relief usually?
Most patients, it's be fairly immediate relief. Some patients might complain of a little bit post-op pain depending on how much natural lordosis they have. The more natural lordosis, because we're laying them prone and we're not taking a lot of it out, it can kind of pinch down on L4, L5, L5S1. They get a little bit of radicular pain maybe, but that should clear up within a couple days to maybe a week. But most patients overall complain of an overall reduced amount of pain. They'll have a little bit of soreness. The nice thing with the 2 screws is you're only going through maybe at most an inch of tissue, and it's mostly just fatty tissue. So when you're doing the posterior, a lot of times you're cutting through some ligaments and muscles and other things. With this, there's very little post-op pain. It's mostly just kind of a discomfort because they're not used to all that stability or that compression. So sometimes patients that have extra lax joints, because there are compression screws, it kind of pulls everything back together. And that little compression, they feel like a little pressure almost. Like it feels better, but it feels kind of weird. But it's just that pressure. Usually that'll all subside within a few days to a week, and then patients are ecstatic after that. And that's not every patient, but those are some of the things you may run across.
Thank you.
Of course.